of hysteroscopy in assisted reproductive technology appear to be controversial, and that is nothing to do with the ability of the hysteroscopy to aid whenever appropriate. It's to do with how some of us clinicians decide to use it. So the outline of my talk will be to talk about just brief introduction to clarify the subject and separate when hysteroscopy is needed and when it is not, and then talk about routine hysteroscopy before IVF, and look at the poor quality studies in the literature, and then routine IVF in relation to the good quality studies in the literature, and apply the same for using of hysteroscopy in recurrent implantation failure. We know that the sole purpose of the endometrium is to enable implantation of an embryo during a relatively short window of opportunity called the implantation window. And there is no question that the soil for that implantation of the embryo is very important, otherwise we will have no result. We are all familiar with this picture where an embryo would like to find the right conducive, receptive environment for it to flourish. And there are so many factors that control this process, but there is no hiding from the fact that only estrogen and progesterone control all these small molecules. And there are so many cytokines and peptides that controls implantation, but still appearance matters. How the endometrium looks will give us an idea about its functionality. And it's very rare that you see a picture like this, that then you find additional pathology over above what you see in the ultrasound scan. And it come in different way and shape, but still with good resolution ultrasound and 3D ultrasound, you can have a fair idea that the endometrium is blameless, and then you can move on to something else. Even if you wanted some clarification, just instilling a little bit of saline inside the cavity of the uterus can give you additional information and reassurance that the cavity is absolutely fine. How about when that endometrial cavity have unwelcome guests, like an endometrial polyp? There is no controversy that this is one of the commonest findings that we have for investigation, and hysteroscopy and dealing with this will be easy and non-controversial. The same for submucosal fibroid or fibroid polyp, or again, endometrial polyp at hysteroscopy, and we tend to remove them on the advice, which is not particularly strong, but conventional wisdom will accept. If you are seeing a polyp before treatment, it is worth repeating to make the environment better. And with fibroid, similar story, submucosal fibroid here need to be removed, can be removed, and there is no controversy here. And endometrial adhesions, again, our tool is hysteroscopy, and we can get good result by doing therapeutic or surgical hysteroscopy for these patients, although in some cases, the adhesions can be so severe that the uterus is rendered, sadly, not fit for purpose, and we have to advise the patient accordingly. And with fibroids, sometimes we have to establish the extension of the fibroid into the cavity, but with availability of 3D ultrasound, resorting to hysteroscopy becoming less and less, and most of the time we resort for hysteroscopy for treatment. And structural anomalies where hysteroscopy comes in, like intrauterine septum, again, that is something that we don't have really strong evidence base for its removal, but expert opinion currently, and considering the patient will go through emotionally demanding and expensive treatment, it makes sense to safely remove intrauterine septum before undergoing IVF treatment. Now, moving to the subject matter, which is, should we use hysteroscopy routinely before the first IVF cycle? Now, it depends which literature you read. Few years back, our team has put together all the literature that's available in a meta-analysis, and the result of meta-analysis concluded that robust and high-quality randomized trials are needed to confirm the findings and to further guide clinical practice. Now, we didn't have to do that well-designed randomized control trial. Our colleagues in Amsterdam or the Netherlands did that study, and they did a large multi-center randomized control trial that was published in The Lancet. Don't worry about reading it, but the bottom line is similar. There is nothing to be gained by doing routine hysteroscopy before IVF compared to doing IVF without it, and you can see the live birth rate in the two groups is identical. So it is categorical. Routine hysteroscopy before IVF does not improve the live birth rate in infertile women with a normal transvaginal ultrasound scan. Now, it varies from one country to another, whether the state is funding or not, whether the patient is paying or not, but there is no question that if you make the process very expensive for the patient by unnecessary procedures, you are depriving the patient of the resilience to try one more time or 3 times in order to get her goals. Because if she exhausts her resources with the first cycle, she has little chance of continuing with the process. Now, routine hysteroscopy after recurrent implantation failure. I will not discuss recurrent implantation failure, but you know how frustrating it is. And when we have a patient failing one cycle after another, we get into desperation, patient and clinicians alike. And under this desperation, we sometimes come up with rational and irrational investigations. And one of the irrational investigations is routine hysteroscopy for recurrent implantation failure, because the same applies. If you have a transvaginal ultrasound scan showing the endometrium to be 11 millimeter, triple line appearance, it's all clear. I have no idea what would hysteroscopy, but let's look at the literature. We did the same. Also, a few years back, we did a systematic review and meta-analysis, and the systematic review and meta-analysis suggested that if you do hysteroscopy, you will improve the outcome for patients with recurrent implantation failure. Whether you find something or you don't, still after hysteroscopy, result will be better. And it was almost too good to be true. How good is the evidence? There were small number of randomized trials available. There were methodological limitation, and there was no or little limited live birth data. So we decided to do a multi-center randomized control trial in 8 European centers. The centers were 3 in the UK, 1 at GSTT, that's our institution, 1 at Barts, where Dr. Hazem used to work, and the other one in Birmingham Women's Hospital, few centers in Belgium, others in Italy, and others in Prague. So the question that we asked, does performing outpatient hysteroscopy before starting an IVF cycle improve the live birth rate in women who had recurrent implantation failure? And we did the analysis by intention to treat, and you can see here the pregnancy rates, the clinical pregnancy rate, the live birth rate, implantation rate, no difference whatsoever between those who had hysteroscopy and those who didn't. The outcome per protocol to include only patients who continued the study after excluding those patients who dropped out, again, there is no difference between those who had hysteroscopy and those who didn't. So the conclusion that I can share with you after this talk, that hysteroscopy is no doubt is a valuable tool in assessing the uterine cavity. Outpatient hysteroscopy before IVF or after recurrent implantation failure does not significantly improve subsequent IVF outcome as a routine, and outpatient hysteroscopy cannot be routinely recommended before IVF or after recurrent implantation failure. And I thank you for your attention.